Okay, so I'm going to start off just by setting the scene a little bit before we get into the crux of the talk. And I guess the origins of cardiology we can probably describe as starting in 1628, when a British physician by the name of William Harvey published his seminal paper, and he was probably the first person who accurately described how blood is pumped by the heart throughout the body. And the way cardiology has evolved and its importance is reflected by the great burden of disease that we have seen established, particularly in the 20th century. So you'll be familiar that there was big global shift away from communicable diseases to non-communicable diseases as the major cause of morbidity and mortality. And cardiovascular disease contributes to a large part of that. And it's no longer a disease of the privileged, it's a disease that we see in the low and medium socioeconomic groups. And even though in the early part of the century, 21st century, we have seen a decline in the incidence, so cancer has surpassed heart disease as the leading cause of mortality overall, although in women it's still the major cause. The overall prevalence is high, and we're seeing the effects of people who are surviving from our advances and innovations in cardiovascular interventions. And this has really propelled how the cardiovascular field has developed and where we are going in the future. So predictions are always difficult, aren't they? But we can expect radical changes in cardiovascular medicine. We can expect those changes to continue whilst there are also radical changes in healthcare. And if we think about predictions, it's fairly easy to talk about the near-term possibilities, and that's what I'll spend some time on. Beyond the sort of 10 years, we're trying to extrapolate from research, and then after that, it's really intelligent guesses. The bioengineering aspects of any field, and it's a big part of cardiovascular innovation at the moment, those aspects will develop quite rapidly. Whereas the interventions that rely on biological understanding and sociology, those things are obviously much slower to progress. So what I'm hoping to do is give you a current state of in cardiovascular medicine and where we're going. And if we look at the future of healthcare, and I'm going to come to this at the end, hopefully, and it'll link together, we can expect healthcare to change quite significantly in this century. So we're seeing shifts in demographics, we're seeing increasingly advanced, expensive technologies, and we can expect what has been described as the creative destruction and then the rebirth of healthcare as we know it. And I'll come to that at the end. Hopefully that'll make some sense. But it's particularly true for cardiovascular medicine, which sees itself at that nexus of aging population, advanced technologies, expensive technologies, and conditions which are very sensitive to lifestyle changes. So just to recap in terms of what have been the major advances over the 20th century, and there have obviously been a number of leaps, but I guess if we were to define some of them, it would relate to our ability to demonstrate a map to surface level the electrical activity of the heart with ECGs, ultrasound imaging to give us some understanding of anatomy and morphological abnormalities, the concept of the coronary care unit, focusing skills and expertise in one area where we can then treat patients and monitor patients is a major advancement. And then there have been some big leaps in terms of drug therapy, and the big hitters are cholesterol-lowering therapy, lipid-lowering therapy with statins, drugs which affect heart rate and have protective effects on the heart, blood pressure-lowering medications. And underpinning this, of course, sorry, I'm shouting to the microphone, underpinning this is a much better understanding of the pathophysiological mechanisms which are driving disease. And undoubtedly, the cholesterol theory of angiogenesis, which was published at the beginning of the 20th century, really did define how things were going to move further. In many ways, cardiology has advanced in what might be termed revolutionary terms, and invasive cardiology demonstrates that very well. And in the early 20th century, Forceman performed cardiac catheterization catheters to examine the heart through the arterial system on himself, and then that progressed to selective examination of the arteries that supplied the heart, the coronary arteries, in the 1960s. And then really the advent of catheter-based interventions by Andreas Grunzig in the late 1970s can probably be defined as a real pivotal moment when we really saw innovations start to progress to a whole other level. So the pillars of therapeutics in cardiovascular medicine up until now and comprise of pharma and medical devices, and we're continuing to see that evolution. And of course, coronary artery disease forms the major burden of cardiovascular mortality and the complications of coronary artery disease-related events. And we know that atherosclerosis, the deposition of lipid, in of itself isn't life-threatening. It causes symptoms when it affects blood flow through coronary arteries, but it's the process of superimposed thrombus, clot, over and above that lesion, that narrowing in the artery, which is responsible for the critical events leading to heart attacks, interruption in blood flow, and depending on the extent of that interruption in blood flow and the duration, you get a spectrum in terms of injury to the heart muscle. But our understanding of atherosclerosis has changed, and so with it, our pharmacological interventions have evolved. And we know that in this cell biological era, our understanding has supplanted that very simplistic concept that atherosclerosis is simply some passive deposition of lipid. And we clearly have evidence which demonstrates inflammatory processes which drive atherosclerosis. And parallels have been drawn with more prototypic inflammatory diseases. And so a lot of work is going into developing targeted biological therapies to target that process. We've also seen just this year now the introduction of the approval of a new drug, and following statins, this is the first drug. Statins were approved, came into introduction in the 1980s, cholesterol-lowering drugs, massive impact in terms of reducing the risk of coronary events, and we have seen effects of that. And this year we've seen the introduction of the first drug since then, really, to impact on cholesterol clearance as opposed to inhibition. And we're looking at that thrombogenesis aspect, clot formation, and drugs that affect clot formation, and tailoring therapies and developing therapies so that they're more effective and safe. And that whole safety-benefit relationship is one that is a constant theme in medicine generally, and particularly in our cardiac interventions. But then not only have we developed pharmacotherapy, as I alluded to earlier, a radical shift has been in catheter-based interventions, and this has really transformed the standard of care of patients. And this is something we've seen generally in medicine. We've moved away from big surgery to keyhole surgery, and this has been demonstrated very potently in coronary artery disease with percutaneous coronary interventions. And we know that people with coronary artery disease who do develop that superadded process of clot formation, thrombus formation, are at higher risk of death and morbidity. And percutaneous interventions in these groups provide benefits in terms of salvaging myocardium, heart muscle, and reducing the complications. But equally, we're seeing people survive heart attacks where they didn't survive before. And this has changed completely concept of heart attack from simply being a wound to the heart to this time is myocardium concept, not simply at a mechanical level, not simply at the level of pharmacotherapy, but in terms of how we work as multiple disciplines from the point of the patient calling the paramedic with their pain to the point of them receiving their acute emergency treatment. And this has been described in the chain of survival for patients who suffer the most extreme presentation of acute events, which is with a cardiac arrest, and how a systematic, coordinated approach, which has to work at every level, is essential to achieve an outcome in terms of patient survival. And we are constantly being challenged. So the idea is not to go into the detail of this, but we are constantly being challenged to our understanding of basic processes and basic science in terms of our current paradigms, in terms of how we treat heart attacks, where our priorities are, better understanding of myocardial protection. And so we are constantly revising our approaches to management of these acute conditions. The advent and the continuous innovation in coronary interventions has led to a continuous drive towards the ideal stents, which are the scaffolds that we implant in coronary arteries when we open up occlusions to ensure the vessel stays patent. And the ideal stent is a scaffold which is easy to use, which is safe, which is efficacious, where we don't have to use a lot of blood thinning drugs for a prolonged period of time. And we've seen recently now early application of what are called bioabsorbable or biodegradable scaffolds. So this is a goal which we're still evaluating and it's still being developed. But the idea is you create scaffolds that are as good as the stents, but even better. So they're fully bioabsorbable. And they have no sort of byproducts. They're fully metabolized with no sequelae, and they restore your normal vessel physiology. Whether we're not there yet, but that is what we are looking at achieving. And of course, if we achieve that, that completely changes how we can manage patients in terms of putting in lengths of metal scaffolding in their arteries and the implications in terms of how that might affect their vessel physiology and how that might affect future options. But as I said, people are surviving, but because people are surviving, we then create further burdens in our healthcare. So people are surviving having sustained myocardial injury which affects the function of their heart, leading to heart failure. And heart failure is a major clinical economic burden to the population. Over 400,000 people affected, over 3/4 will actually have evidence of poor pump function. And there are multiple approaches to treating heart failure which have evolved, not simply from the symptom management of using drugs to try and deal with the effects of pump failure, but mechanisms, therapies which actually improve the prognosis of these patients. Moving on to really advanced support devices for the heart and cardiac transplantation. But at the other end also, there is an awareness that we are treating patients who may have end-stage disease, and a holistic approach which recognises the palliative needs when patients are at that stage in life have become more and more part of our management in cardiovascular medicine as we deal with a more ageing population. Perhaps one of the key advances and major areas of innovation that we are seeing at the moment, and perhaps this is with some bias because this is part of the field that I work in, so I declare that, but one of the major shifts is following the stent revolution, which has dealt with an alternative to open heart surgery for patients with coronary artery disease. We're now seeing the application and development of alternatives to valve surgery. And this is highly relevant because we've seen dramatic shift in epidemiology in valve heart disease from what was predominantly rheumatic heart disease to what is now predominantly disease of an aging population. And there are two key valves in the heart which are of interest. And this has led to a lot of scientific, bioengineering, commercial interest in developing valves which can be introduced via catheters, via the arterial system, as an alternative to open heart surgery. And of course, the benefits here are that one expands options to a patient group that hitherto wouldn't have had the ability to undergo surgery, not because they didn't have an indication per se, but they're too frail, their comorbidities are too high, recovery from surgery would be quite protracted. So there's an expansion in patient base with the goal of achieving effective outcomes which are safer and, of course, cost-effective. And that underpins all of our innovations in the current day. And these approaches to cardiac interventions have resulted in quite big changes in our whole way of working and the principles of working. And we've moved away really from, or we are moving away from very sort of working within silos and recognizing a more disease-orientated approach where we see the interfaces between various groups, surgeons, ourselves, as being much closer and blurred. So this is just an example of valve technology as an alternative to heart surgery. So this is an aortic valve which connects the main pumping chamber of the heart, allows blood to the rest of the body. As we get older, we can experience a degenerative, well, probably more a degenerative and inflammatory process, not too dissimilar to atherosclerosis, which affects the valve, which becomes more narrowed. Patients become breathless. There's a mortality risk associated with that. But we're seeing more patients with this condition. They're living longer, but they're not necessarily able to undergo surgery. So this is all delivered via a keyhole, less invasive approach, and recovery following these procedures is naturally swifter. And we've seen quite radical advances just over the past 10 years, and that's nothing, is it really, in the whole evolution of medical technology? If you think that surgical practices have evolved over 5 decades, we've seen quite revolutionary changes in the treatment of this valve disease, and it continues to drive the indications further and further and broader to more and more patient groups. And we see it also with mitral valve. This is a valve that is on the left side of the heart, much more complex valve, much more challenging in terms of developing techniques, but these are all techniques that we are now incorporating and indeed sharing with surgical colleagues, and that really reflects a change in our practice. In all of this technology-based intervention, the question arises, and we are challenged in terms of appropriate application of these technologies. So, can I do it? Yes. Should I do it? Is often a question that we don't get right, and we are developing better means of stratification and assessment to determine which patients will benefit. And trials, data constantly underpin these areas of innovation to help guide that risk-benefit analysis to determine which patients will benefit. And so this is a form of transformational technology. We are seeing changes in practice, changes in guideline. We're seeing new technologies emerging that challenge standard of care. Whilst there is still relative paucity of evidence, all in an information era, of course, when patients have perceptions and expectations which often outpace and surpass where we are in terms of evidence. And that's a real challenge, and that's why evidence remains a cornerstone of our practice. We see developments in terms of therapies, drug therapies and invasive therapies beyond these fields, in fields looking at abnormal heart rhythms, arrhythmia management. And we see application of modern tools now, 3D imaging tools, which can create a virtual picture of the heart to guide cardiologists who are trying to establish the source of complex heart rhythm disturbances. And so that innovation drive continues apace, and whilst you're right in thinking that this is a very device-orientated approach, the reality is that as our understanding of disease mechanisms improves, we will certainly move away from being from a sort of mechanical approach towards a more biological approach. And there's a lot of research and a lot of expectation in terms of cell therapy, not only to target injured muscle and tissue and regeneration, to target potentially therapies where you could have biological pacemakers, obviating the need for devices. And so there's a whole potential role for this, which we can look forward to in the coming decades. Perhaps it would be fair to say that the one field of cardiology that underpins all of this is the field of imaging and diagnostics, which brings together all our tools and technology, all the armamentarium we have in the treatment of cardiovascular diseases, whether it's coronary disease, whether it's rhythm disturbance. And we have seen the potential role of imaging perhaps in search of that magic bullet, which is not intervening when the disease has progressed to a point where it causes morbidity or mortality, but detecting disease at a subclinical level. And in this sense, there is a really pivotal role of imaging and diagnostics, which has seen massive evolution over the century, and we're seeing further applications in this area, particularly with CT and CMR imaging. And just an example of that is how we can use CMR imaging almost as a form of a biomarker. So this is an example in patients with thalassemia. So this is an abnormality with a protein called hemoglobin, oxygen-carrying protein. So patients become anemic, often become transfusion dependent, and that transfusion dependency can cause iron overload and has been a major cause of morbidity and mortality. CMR can be used to actually detect that myocardial iron before it's actually caused clinical sequelae. And so you have in your possession the ability to permit early diagnosis at a subclinical level. But it's not just imaging. We are seeing already where the future is heading in terms of digital and nanotechnologies, so wearable technologies where patients can be continuously monitored, and these patients who may have chronic conditions, who may still be susceptible to acute events, and we can modify their treatments early. We can limit perhaps morbidity. 3D imaging, which I've mentioned briefly, 3D bioprinting, which allows us to understand anatomy and morphological anomalies better, which allows us to guide our interventions better, which allows us to communicate with our patients better and enhance our understanding, and perhaps even create 3D bioprinting sort of dedicated valves which can be custom made for an individual patient. We might see that in the future. And the role of nanotechnology to actually deliver therapy at that nano level. So these are all things which are very much here in terms of technology that we are aware of and is developing, and we can expect to really change how we practice medicine. And that really takes me back to the point I made at the beginning of the talk about how we expect healthcare to change, how we expect healthcare as we know it to really be reduced and then restarted in a completely different form. So imagine at the moment we have a symptom, you go to the doctor assesses your symptoms, examines you, investigates you, establishes that there might be a disease, an underlying pathology that needs to be treated. We've moved on from that. We certainly have lot of evidence-based data which guides our therapy and our interventions, but how about turning that completely the other way around? Before you even have symptoms, we can detect changes that are occurring early. We may not even require doctors at that stage to intervene. And what I'm talking about, I guess, is this fashionable term. I don't think it's a fad, but I don't think it's a new concept, precision medicine, but I think we now have tools and technologies which are going to be able to realise the concept of more customisable healthcare, tailored healthcare. There is an overlap with the term personalised medicine, but where we are able to recognise an individual's variation in terms of lifestyle, environment, genetic susceptibility, and tailor how we deliver treatment. This is all exciting, but of course, as with any innovation in cardiovascular medicine, really does espouse this human drive to constantly develop and innovate. It generates debates. If you can get a molecular profile, a genetic profile of an individual, if you know what I might suffer from in the future before I even have any symptoms, who else is going to know? How is that data handled? There are issues about ethics, there are issues about costs, there are issues about how we manage all these data. And I think the reality is that all these factors will mould how we deliver these technologies over the coming decades. Technology isn't a neutral force in any shape or form. It's very much an active process which is underpinned by better scientific understanding, but within a framework of values. And I'm going to stop there. Thank you.